Today, we'll be discussing a specific type of heart disease called pacing-induced cardiomyopathy, or PCM. This condition develops in some individuals who receive cardiac pacing for slow heart rates. While pacemakers are often life-saving devices, prolonged, non-physiological pacing can, in certain individuals, lead to a weakening of the heart muscle. We'll explore the causes, how it develops, the symptoms, diagnosis, treatment, and ways to prevent this potentially serious condition. The primary cause of pacing-induced cardiomyopathy is prolonged, predominantly right ventricular apical pacing. Let's break that down. Cardiac pacemakers are commonly implanted to treat bradycardia, which is an abnormally slow heart rate. Traditionally, the pacing lead is placed in the apex, or the bottom tip, of the right ventricle. This unnatural activation sequence disrupts the normal coordinated contraction of the heart. While necessary for maintaining a minimum heart rate, constantly pacing from this location can lead to electrical and mechanical dyssynchrony, setting the stage for the development of cardiomyopathy. The extent to which someone is dependent on the pacemaker also plays a role. The more the heart is artificially paced, the higher the risk. Now, let's delve into the how, the pathophysiology. Normal heart contraction involves a precise, coordinated sequence of electrical activation that starts in the sinoatrial node, the heart's natural pacemaker. This spreads through the atria, then to the ventricles via the AV node and the His-Purkinje system. This system ensures the ventricles contract efficiently. Right ventricular apical pacing bypasses this natural system. The electrical impulse travels from the right ventricle in an unnatural way, creating a left bundle branch block pattern. This asynchronous activation leads to inefficient contraction. Over time, this altered contraction pattern causes structural changes in the heart muscle, including dilation of the left ventricle and impaired pumping function. The heart tries to compensate for the inefficient contraction, but ultimately this leads to heart failure symptoms. Pacing-induced cardiomyopathy isn't uncommon. Studies suggest that a significant percentage of patients receiving long-term right ventricular apical pacing can develop PCM. Estimates vary, but it's believed that anywhere from 10 to 20% of people with traditional pacemakers develop some degree of left ventricular dysfunction attributable to the pacing. The risk is higher in individuals with pre-existing heart conditions, those who are heavily reliant on pacing, and those with wider QRS duration on their EKG. The signs and symptoms of PCM often mimic those of other types of heart failure. Patients may experience shortness of breath, especially with exertion or when lying down. Fatigue and weakness are also common. Swelling in the ankles, legs, and abdomen, a condition known as edema, can occur due to fluid retention. Some individuals may experience palpitations or an irregular heartbeat. Because these symptoms can be similar to other heart conditions, it's crucial to consider the possibility of PICM in patients with pacemakers who develop these issues. Diagnosing PCM involves a combination of clinical evaluation and diagnostic testing. A thorough medical history, including the patient's pacing history and underlying heart conditions, is crucial. An electrocardiogram, or EKG, can reveal evidence of left bundle branch block pattern caused by RV apical pacing. Echocardiography, an ultrasound of the heart, is essential for assessing heart size, function, and valve abnormalities. It can show left ventricular dilation and reduced ejection fraction, indicating impaired pumping ability. Further testing such as cardiac MRI or other advanced imaging modalities might be required in some cases to rule out other causes or evaluate for myocardial fibrosis. While there aren't distinct types of PCM in the same way as, for example, different types of valve disease, PCM is typically classified based on the severity of the heart failure. The New York Heart Association's NYHA functional classification is often used to describe the severity of symptoms, ranging from Class I, with no limitation of physical activity, to Class IV, with symptoms at rest. The severity of left ventricular dysfunction, as measured by ejection fraction, also contributes to classification and guides treatment decisions. The primary goal of treatment is to improve heart function and alleviate symptoms. If possible, the first step is often to optimize the pacing strategy. This may involve reprogramming the pacemaker to reduce the amount of right ventricular apical pacing, or even upgrading to a biventricular pacemaker, also known as cardiac resynchronization therapy or CRT. CRT involves placing pacing leads in both ventricles to restore a more coordinated contraction pattern. Medications commonly used to treat heart failure, such as ACE inhibitors, angiotensin receptor block beta blockers, and diuretics, are also used to manage PCM. In severe cases, advanced therapies such as left ventricular assist devices, or LVADs, or heart transplantation may be considered. Regular monitoring and follow-up are essential to assess response to treatment and adjust the management plan as needed. Prevention is key to minimizing the risk of PCM. When considering pacing for bradycardia, the initial choice of pacing site is crucial. Whenever possible, alternatives to right ventricular apical pacing should be considered. These include pacing from the right ventricular septum, which is a more physiological location, or his bundle pacing, which involves pacing directly at the heart's natural conduction system. These pacing modalities can preserve more normal electrical activation. For those already receiving RV apical pacing, regular monitoring of heart function with echocardiograms is important. If signs of early left ventricular dysfunction are detected, intervention with pacing optimization or upgrading to biventricular pacing can be considered. The prognosis for PCM varies depending on the severity of the condition and the response to treatment. Early diagnosis and intervention can often improve outcomes. Biventricular pacing or CRT has been shown to reverse remodeling of the left ventricle and improve heart function in many patients. Recent research focuses on refining pacing techniques and identifying individuals at highest risk for developing PICM. Studies are also exploring the potential of novel pacing algorithms and technologies to minimize the detrimental effects of pacing on heart function. Continuous advancements in cardiac pacing and heart failure management offer hope for improved outcomes for individuals at risk of or affected by pacing-induced cardiomyopathy. Thank you for watching. We hope you found this informative.